All right, so we are ready to go. So I just want to introduce our presenter today. Thank you so much to Dr. Anna Chodos for offering to present these updated guidelines to all of us. Dr. Chodos is the Assistant Professor of Medicine at UCSF within their Division of Geriatrics, and she actually participated in creating the clinical care guidelines that we're going to be learning about today. And so I'll keep the introductions brief and pass it over to Dr. Chodos.
Thank you so much. Can you hear me okay?
Yes, this is perfect.
Great, wonderful, and thanks everybody for tuning in. I know this is really exciting. It's always nice to have a new guideline to help us think about our practice and improve our practice. And thanks, Pauline, and to the Alzheimer's Association for sponsoring the time to do this webinar. So just so everybody knows, I'm, as Pauline said, I practice in San Francisco, and I'm actually a primary care provider as well as a geriatrician. So I have 2 outpatient practices in primary care and geriatrics at San Francisco General, and one of our main focuses in geriatrics is in cognitive impairment. But just to point out that as we go through this guideline, I think many of you will see that this is really meant for all providers and general providers, not necessarily specialty providers who may have a focus on cognitive impairment in their practice. So this was meant to be broadly applicable, and I hope that people find that that's so. And in terms of the background, just to support what Pauline said, there were several meetings of many experts and people involved in dementia care specifically, as well as general practitioners, as well as people who are neuropsychologists or psychiatrists and other allied health professionals that work with older adults with dementia. So this has been a cumulative effort in that regard. So hopefully people find this useful. In terms of this specific presentation, I really just, I stay really stuck to the guideline as it is because it did just come out. I didn't have a lot of time to make this presentation really go beyond that, and there's a lot here. So I'm hoping that it's useful and that you guys have questions that can help me understand maybe what isn't clear about either the guideline or the way I'm presenting it. So looking forward to your questions as well, but I'm going to try to ignore the chatter until I'm done speaking, and I will try to be very efficient. So let's get started. The roadmap for this update, we're going to talk about, again, the format. I'm going to follow the format of the guideline itself, and we'll talk about some of the more recent evidence about the impact of Alzheimer's disease, and really this is applicable also to related dementias, particularly around the clinical care planning aspects. We'll talk about some of the new government policies and evidence in clinical practice for updating this guideline. And then finally, we'll just get into the second page, which we'll try to spend our most time there talking about the clinical care guidelines themselves. And the way it was split up after a lot of discussion was to focus on the assessment piece of dementia and monitoring, the care plan piece in terms of sort of everything that's happening in between the monitoring points and the diagnosis, the initial diagnosis. We want to put a big emphasis on education and support and that's really, if you think about it, part of the care plan, but we really wanted to emphasize it because it is such a crucial aspect for adults with dementia and their caregivers. And then finally, we also wanted to call out some very important considerations that seem to need to have a little space of their own to make sure those aspects get highlighted. So, sorry if I have trouble advancing. Here we go. So the update, as Pauline mentioned, is really, it's about 10 years after the last one, and it's to incorporate new evidence, make reference to improved practices in caring for adults with dementia, and then also just to reflect some changes in the law. And then, as I mentioned, you'll see that this is really hopefully to be useful to on-the-ground clinical providers. And what I thought a cool part of this particular guideline is if you are looking at the guideline on a computer and you've downloaded it or you're, just have it live in a web browser as opposed to having it printed out in your clinic or something like that, you can actually, throughout the guideline, there are links to hopefully useful resources for you all throughout the process of managing dementia and diagnosis. So that was a new thing as well. So let's talk about the disease and its impact. As the guideline mentions, but I'd like to highlight is that we know that dementia, really it is a two-part diagnosis. It's referring to new cognitive impairments, used to really anchor on memory loss, but now there's more emphasis as well on other cognitive domains, so that there's evidence of that loss of a cognitive domain, possibly memory, and that it interferes or interacts somehow with daily life. So because of this impairment, which is acquired and progressive, that you're also seeing an impact on daily life and function. So I always like to highlight that it's not just the cognitive impairments themselves, but it has to be impacting function in order to be dementia. And we know that Alzheimer's disease is the major cause of dementia, and it's up to 80% of cases, and we know that over 500,000 Californians are impacted, and this is the 5th leading cause of death in California. We also know that it disproportionately affects women, and about 2/3 of those affected with Alzheimer's in the United States are women. And we also know that the impact of dementia care impacts women more heavily, as women are much more likely to be caregivers for someone with dementia. We also know that there are racial and ethnic disparities in dementia in California, and that African Americans and Hispanics are more likely than white adults to have dementia. So roughly on the order of 1.5 to 2 times as likely in both Hispanics and African American populations. So for those of you working with African American and Hispanic populations more, you may see a higher prevalence of dementia. So let's move on to the evidence for the update, why we were doing this now, other than time simply passing. One reason was just to highlight some changes in government policies, so I'll speak to those briefly. So one is that there's new ways to get reimbursed for addressing cognitive impairment and dementia. So one thing, I'll talk about that in the next slide actually, and I'll just highlight the main government policy changes here. The other is that we've adopted the PULSE form in California. So it sounds like many of you may be using that. There's also, just wanted to make people aware of the Social Security benefit for people with dementia who are diagnosed at what's considered early onset or under 65. And then finally, there's a big push from the CDC around the Healthy Brain Initiative. So coming down from, federal government, a real push to get people to understand the importance of healthy brain activity. So again, just digging in briefly to the Medicare reimbursement changes. So there's the annual wellness visit. I don't know how many people in practice have been able to successfully implement this, but many practices certainly are trying. So the fact that people over 65 every 12 months can get an annual wellness visit, and you can bill for that from your practice if you do all the elements. And one of those is a cognitive screen. So it's wonderful to see that as part of that. And that really speaks to something we'll talk about later, which is early detection. Or frankly, detection at all, but of course, early detection as well. And then the thing that's also a lot of people have been talking about is that the Medicare will now pay in different ways for services for patients with cognitive impairments if you're actually doing the care planning and documenting the care planning. So that includes things like cognitive, repeat cognitive assessments, functional assessments, and documentation of care planning around issues having to do with the dementia. And those are new codes that are coming out. And unfortunately, in my practice, we have not implemented these, but these are things that I think the Alzheimer's Association has written about and publicized elsewhere as well. So things like the CPT code G0505, I believe it is. Then there's the adoption of the PULSE. I don't know how many of you are aware of this, the physician order for life-sustaining treatment. It's often a hot pink form that patients will fill out with their providers and surrogate decision makers front and back, indicate that they have certain preferences for end-of-life care and that these should be respected, particularly in the scenario of people not wanting treatment, like being brought to the hospital or having resuscitation in the field. And it's been found, there's evidence that this reduces patient and family suffering by addressing these issues ahead of time and having a plan. And certainly, very importantly, in the case of an emergency, can be critical in protecting someone's wishes. This is obviously very relevant to people with dementia who have a progressive and often fatal course with the disease. And may very appropriately be good candidates for to have a post. And then there is the Social Security Compassionate Allowance, just to make everybody aware who are working with those who may have early onset diagnosis patient in their care. This is something that they could be connected to, and it does not require a ton of information from you. And I am seeing some questions, and we will get to them. Just want to make everybody aware if they're coming up for you as I'm talking. We'll make sure to go through them all as much as possible, certainly. And then finally, the Healthy Brain Initiative. I don't know how many of you have looked at the materials, but they're great, and really trying to emphasize the public health strategies around managing people with dementia, both monitoring and evaluation of cognitive and functional status, doing education and training of the workforce and caregivers, has goals for policy development, and also for workforce competencies, and also actually just good materials to give patients about healthy brain activities. So I put the website there on the slide at the bottom to check out the Healthy Brain Initiative. Okay, and then practice trends. Has there been anything of note that has changed in the last 10 years that could contribute to this guideline? And certainly there has been. And specifically, it's been that, despite evidence of being able to modify the disease progression by detecting it early, there's been shown to be other benefits to early detection, diagnosis, and even a more robust effort at diagnosing mild cognitive impairment, which is cognitive impairment without functional impairment yet. So you would think for many a pre-dementia stage possibly. There's also been a lot more evidence about the harms of antipsychotic medications in patients with dementia and adults with dementia, there's been evidence around more studies showing gaps in disclosing information and documenting dementia diagnoses. And finally, continue to be more evidence for lifestyle modification benefiting people with dementia. So just to dig in a little bit on that, we know that early detection and early diagnosis can change people's lives and can certainly impact quality of life. And again, I sort of alluded to already that mild cognitive impairment, while does not meet the diagnosis of dementia, because someone may be showing some signs of cognitive impairments without actually having any functional impairment yet, there is increasing work and effort to identify these people, one, to possibly offer them research opportunities, and also to focus more heavily on lifestyle modification and other things that we hope will show to delay the onset and slow progression. Then there have been many, so in 2005, which was obviously before the last update, there was the black box warning to indicate that antipsychotics are associated with an increased risk of mortality in those with dementia-related psychosis specifically. But there's just been multiple meta-analyses. I'm happy to, in a future update or review of these guidelines, I did not feel the need to list them all here, but there has been meta-analyses of meta-analyses at this point showing the harms of both conventional and then the second generation atypicals and even next generation after that, antipsychotics for those with dementia-related psychoses. I think the main thing there is also the reason to highlight this is that they're really heavily used as well to treat these behaviors. So this will maybe speak to what we'd like to talk about around education and support and care planning on the second page of the guideline about how these medications do or do not come into play. We know that there are a lot of gaps in disclosure and documentation. Again, more evidence to support this so that it's not only 45% of patients are billed for Alzheimer's-related care. Were actually told that they had this diagnosis. And there's concern and some evidence to suggest that overlooking these diagnoses and not disclosing early can impede care, access to appropriate advanced care planning, impede quality of life for caregivers and those with dementia, So really a patient-centered approach would recommend that as soon as a diagnosis is made, that it's disclosed and documented thoroughly. And finally, there's more evidence for lifestyle modification to protect the brain in those, pre-dementia, pre-mild cognitive impairment, and then to improve function in those who have dementia diagnoses. So managing cardiovascular risk factors medically as appropriate, encouraging tobacco cessation, weight management, and then definitely physical activity. And then there's some evidence for those without dementia to see some prevention from things like the Mediterranean diet. And since these are US-based guidelines, we can't all move to Spain just to prevent dementia, but it certainly seems like there's some benefit there from the studies coming out from the Mediterranean diet. So now, thank you for listening to me. I know I'm going really pretty quickly, but I did want to leave time for this piece, the clinical care guidelines. So really wanted to get to this, and I hope what I just reviewed helped set the stage for this. But again, as our roadmap suggests, I'm just following the way the guidelines currently organized into assessment of dementia, care planning for dementia, education and support for those with dementia and their families or caregivers, and then finally want to highlight important considerations when working with adults with dementia. So there's sort of these subtitles to each section: assessment, understand the patient, care plan, beneficial interventions, education and support, engage with the community. And that really speaks to the fact that a lot of dementia management is outside of our clinic or healthcare environment. And it's really about what's going on with that person and their support system in the community. And then important considerations, we also just made sure that these are things, we're highlighting them because they're time sensitive. So hence the subtitle there. So let's talk about assessment. And I'm sure there will be many questions here. So obviously, you need to assess your patient or person to understand if they have dementia. I can imagine, as I often get clinically, there may be some questions around how you actually do confirm the diagnosis, and this guideline doesn't necessarily go into that in complete, algorithmic stepwise fashion, but it is. We did want to emphasize when going over this guideline that confirming the diagnosis, of course, is important. And that, I guess I just want to add that sometimes that takes time. You shouldn't expect to be able always to confirm dementia, particularly when it's early and things may not be as obvious clinically on testing, that you want to, you may take time, and being, open with that with your patients is completely reasonable. But then if you have confirmed the diagnosis, again, to meet this gap and close this gap between knowing a diagnosis and disclosing it to patients and caregivers, you do want to disclose it, and then you want to document it. So these are really the main steps in good practice, good hygiene around charting and planning, starting the planning for dementia diagnoses with your patients. We had so many discussions and really wanted to highlight the fact that there's a lot, particularly in our very diverse California population. There are things that may have to do with cultural issues, personal values, language issues that affect the decision-making process for the person and their caregivers or family. So obviously these are things just to be aware of and incorporate, as I'm sure you all do in your regular work, but to do that just as robustly around dementia, which can have a lot of cultural valence for people. And then identifying caregivers and documenting that and assessing who's helping the person and with what, how robust is that network. We also, particularly in San Francisco, I know a lot of other counties and communities as well have a lot of older people living alone. And of course, not surprisingly, many of those people are developing dementia. And so understanding who the support system is and making a point of documenting that. And then this, of course, although we don't have an official way to do this in a lot of ways, we felt it was important to highlight that including a caregiver assessment is just as important to the assessment of the person with dementia as any other part of the care, because that person's health and well-being is going to directly affect that of the patient that you're also assessing. So then, I'm sorry for some of the text getting a little squished, but the next part was you've assessed the patient in all these aspects, so you have some key sort of scaffolding and clear diagnosis for if this person has dementia and what their circumstances are. But then that's not it. So you do need to monitor and reassess on regular intervals and at the point of decline. So sudden changes or decline. And if not that, then at least annually was a recommendation to conduct and document how that person's doing functionally, particularly around finances, medications, and all the activities of daily living. Monitoring cognitive status. And the recommendation is to use a tool, and the same tool at each time is probably the best way to go. So a tool that you're comfortable with in terms of getting some cognitive assessment. Some people may have access to more robust testing, like neuropsych testing in their community, or they may have somebody within their practice, like a social worker who has some experience doing cognitive testing and may be the one doing it in the clinic and using a certain tool. But if not, and if you're doing it on your own, taking some time to find a tool that you're comfortable with and that you would be willing to use in your patients regularly is probably the best approach. And then also looking at comorbid medical conditions, as these often impact how the person with dementia is doing, and the dementia impacts how you're going to manage those comorbid medical conditions. So as the dementia gets worse and life expectancy decreases, not potentially managing diabetes as strictly as before, as you're not going to get the benefit from tight glucose control, and it's going to be harder for the person to manage it. So things like that, that was the thought behind those recommendations. And then the other aspect of monitoring and reassessing is the fact that emotional, behavioral, and mood symptoms occur in almost all people with dementia, so in the 90% range. So making that a part of the quote-unquote cognitive assessment is key. Assessing medications, prescription and non-prescription, as many may, again, no longer have benefit or may have consequences in older people, be what we may call inappropriate medications for those with dementia, such as those with anticholinergic properties. So assessing medications quite frequently to make sure that harm is minimized and benefit is maximized. And then lastly, the home environment, which we know is so important in those with dementia. If there's any concerns for safety, if they have enough care support in their home environment, and then any concern for abuse or neglect. So some sort of abuse screen, or neglect would include self-neglect as well. And I'm sure there's I see so many great questions. So just want to thank you for those as I continue. I want to let you know I am seeing them. The care plan piece, so now you have a documented diagnosis and you have a plan to monitor, and you've gone through these elements. Again, not all of them would have to happen at the same visit. So a lot of this happens over time. But then what elements of the care plan are really key? So the dementia-specific ones, really disease management, this is referring to disease management of the dementia, would be to not only disclose that the person has dementia, but to try to get a sense, and of course this can be somewhat squishy as the person changes over time and sort of goes from mild to moderate / severe to severe. But discussing that there is progression and that there are stages and what that might look like. Again, evaluating and managing comorbidities in the context of the dementia diagnosis, because that can really, I won't explain again, but that can really change things. Consider using the appropriate dementia medications and seeing if that person responds well, and considering a trial of those medications. So the cholinesterase inhibitors in mild to moderate, and the NMDA antagonists, otherwise known as memantine or Namenda, in moderate to severe, is the clearest indications for those two medications. And then finally, immediately thinking of referring to community resources that support people with dementia and their caregivers. So these are really the pillars of disease management. sorry, I'm trying to advance, excuse me. Okay, and then as I mentioned, the commonness of emotional behavior and mood symptoms really requires that we keep this as a strong part of our care plan. The current recommendation is that what are really called neuropsychiatric symptoms of dementia are treated non-pharmacologically first, if possible. And that, of course, requires a really intense focus on the people around the person with dementia, because that is often what ultimately is the treatment for the person with dementia. So it's very hard to get them to change, but their reactions of their caregivers and the approach of the caregivers can often really change behaviors. So again, environment modification and counseling through the caregiver, task simplification, so reassessing that person's daily activities and things like that based on what they're really able to do, and then keeping them active and maybe doing activities that helps distract or sort of, keep a routine going for that person. Of course, our mental health professionals are key in this area. I think every place is probably different in terms of how mental health professionals and medical professionals work to support people with dementia and their caregivers. But I certainly have found that they have a really important role, particularly those who have more experience working with those with dementia. And then we talked about this, that there are pharmacologic approaches to target neuropsychiatric symptoms, mood symptoms, such as the antidepressants is usually first line, but then also a lot of people will target specific psychotic behaviors with antipsychotics. But the real recommendation is that be tried in the situations of extreme stress or extreme harm to themselves or others, or in the case that these other approaches have failed. And I'm sorry I don't have more time to go into that. It is a very important topic on its own. And then finally, the absolute, again, pillar, which is, I think, sometimes very difficult to achieve in a healthcare medical model, is the support and education of caregivers. Again, Alzheimer's Association is often a key resource in that regard, and I think many of you in your communities may have other resources that you regularly go to or think about. But in the case of, again, of caregivers being able to be supported to then support the person with dementia, there's really no way around having to connect them to resources and emphasize that basically this is a job that they've not been trained to do and are not educated to do necessarily. Some are, of course, and the more that they can learn themselves and get support themselves, the better the person they're caring for will do. Then part of the safety issues that come up sort of early in care planning and then may often need to be revisited are things like driving. So at some point, many people lose the ability to drive. Certainly when somebody's moderate stage, it's really not appropriate. Wandering behaviors can become a very serious safety issue for some. Obviously, a lot of people with firearms, so screening for firearms in this population is key. And then fire hazards. Do they use a stove? Do they have access to the stove? Are there other fire hazards? I'm sure all across California there are many. And of course, I was at a patient's home yesterday and the stove was on because that's how she heats her house. The burners were on. So this comes up all the time. So asking about those issues and then addressing them. Some people have the resource to order home safety evaluations. Some systems don't have that, or communities don't have that, but that is one approach. And then driving, there can be a conversation about it, but often we're also mandated reporters and need to talk to our departments of public health about the diagnosis, who then often talk to the DMV. Then medical identification, again, if somebody's wandering, I think about this immediately. So we were recommending considering this as part of the care plan for folks, as often sometimes people start wandering and that was not a behavior before. So there are different ways to make sure people wear medical identification, but one of the most common is getting a medic alert bracelet. So that resource is on the guideline. Then goals of care, a key part of the care plan. And again, one that came up with the PULSed, but the way we talked about it while forming this guideline and thinking about it is obviously palliative care and end-of-life options, particularly hospice when people's functional abilities decline and they become eligible. These are wonderful options to support patients with dementia, and certainly is an issue for many, many patients. So being aware that of the palliative care resources and the appropriateness for your patients with dementia is a wonderful option. The other is just the overall, there's a ton of advanced care planning that can be done around both legal and healthcare advanced care planning. So if you think about the fact that those with dementia are almost certainly going to become incapacitated at some point, what impact will that have, and what goals do most patients have around their care when they're incapacitated? So often that's to have a adequate surrogate for healthcare decisions and for legal decisions. So for the healthcare decisions, some of this you can decide ahead of time and help them complete things like do not resuscitate orders of the PULSed, which includes, among a couple other things like preferences for feeding tubes, includes a do not resuscitate order. But then there's things like a durable power of attorney for healthcare decisions and for legal decisions. Those are separate things. So helping them think through that and planning for that. And then finally, of course, they have a dementia diagnosis, but that doesn't preclude ongoing healthy living and may, in fact, improve function and maintain it for longer. So we certainly wanted to highlight that it's important to promote ongoing healthy living in older adults. Talking about if they do have cardiovascular risk factors, that it may still be important to address those, and that regular physical activity and ongoing efforts to eat a healthy diet and get adequate nutrition are very important. And I sort of, again, always emphasize this in the context of healthy brain activities. And then there is a link in the guideline to actually find opportunities to participate in research if that's something that people are interested in. It obviously very much depends on your patients, but some people really are passionate about enrolling in trials or getting, being able to contribute in some way. So that link is included in the guideline. Great, I know that was a lot. We're going to move on, and I sort of touched on it already. The next two sections are a little shorter. And this next section, education support, will emphasize some of the things I just talked about. So in terms of education and support, the one thing I think the group really wanted to emphasize was for many of our patients with dementia, sometimes once that diagnosis is made, they start to be cut out of the care planning a little bit. And just to point out that really throughout, until very severe stages, many patients can still be directly involved in care planning, making treatment decisions, and thinking through and understanding the appropriate referrals and helping to come to what an appropriate sort of referral plan would be. So referring to different day centers or programs, things like that. Again, the care plan and assessment piece of this guideline, we're trying to help providers identify places where you can find needs for home and community-based programs. So then working with your other team members in your healthcare setting to refer appropriately based on that. So if home safety is an issue or activity is an issue, I'm trying to address those, for example. And then there's so many, I know San Francisco is sort of small city, but so and with a lot of different ethnic and racial demographics that sort of have their own culturally appropriate organizations, but that's obviously a very important consideration in our diverse state of thinking through, maybe even if there isn't a specific senior activity at the Arab Cultural Center, maybe it'd be nice to refer them and see if they can make a connection there. But there are just many, I think, culturally appropriate services, so to consider that as well. And then the Department of Public Health program, we just want to make sure everybody has the number. They are able to talk to folks if you really don't have good support to help link people. It's never the wrong thing to call and help them get resources through the phone number as it's listed here. And then, of course, there's the website as well, which can help you find local resources to connect them to. And then finally, just to highlight some really important considerations that should be addressed at some point. And again, we just wanted this extra space to call out these particularly impactful aspects of care planning for people with dementia. So really, they're also sort of time sensitive, and so we'll go over what I mean by that in each of these specific ones. So, for example, for advanced care planning, as I mentioned, that the fact that many people will be incapacitated at some point, so basic legal, financial planning, as well as healthcare planning is really important. And this resource actually is available particularly for legal services to help people with advanced care planning. But the real time-sensitive issue with this one is just trying to get people when they're in the mild to early moderate stage and they can still participate. Because actually I did see one question on the chat side. When people are incapacitated, that essentially means the ship has sailed. It doesn't mean that a lawyer can't help them, but if they don't have a surrogate, then and they can't make decisions, I think we can all imagine that it's in many cases it may be sort of too late for them to be the ones to indicate who's the right person, and the law or adult protective services or other folks who have the authority to get involved may have to get involved instead, and that is often a messier and less pleasant experience than if the person, when they still had capacity, was able to choose, their family member who is the most reliable and the most available, or friend or whomever is sort of important in their life. So advanced planning, if possible, should be in the earlier stages. The other is this issue of capacity evaluations, and I'm sorry, the subtitle there got lost. But without getting too much into the weeds, in our practice, typically we think of decision-making capacity as decision-specific. So often people will have decision-making capacity around smaller decisions, like if they want to go see a specialist or not, but for a certain issue that may not be severe, but in terms of consenting for a really large surgery with big implications, they may not. So trying to get a sense of where they are in that, and also trying to find a legal surrogate or a healthcare surrogate sort of as soon as possible if someone appears to not have capacity. So it's kind of re-emphasizing what I just talked about, but the fact that I think for a lot of us, the issue of capacity specifically gets separated, and noting that capacity is used often in the medical setting and competency is used often in the legal setting. And a judge will decide if someone has competency or not. The issues around capacity can get quite complicated in the setting of limited literacy or language or cultural differences or barriers. And so that this may be something, again, another reason why to address this as early as possible and try to get surrogate decision makers documented as soon as possible. Elder abuse is unfortunately extremely common problem in those with dementia. And so we really wanted to highlight this and point out its really negative impact on quality of life, safety, and healthcare use and mortality in older people with dementia. So elder abuse is a huge term. There's many different kinds: physical, sexual, things like isolation or just neglect by caregivers. And then there's this category of self-neglect in those who lack ability to care for themselves as a result of dementia. So that's also a more common one in the context of dementia than other kinds of elder abuse. And finally, financial. There's essentially a huge industry around financially exploiting older adults, and particularly those with cognitive impairment. So just being aware to this, there is not a strong recommendation necessarily around screening, but this is a very high-risk population. So we wanted to call it out and give it some space and to say that if you suspect it, typically you are a mandated reporter to report it. And in the context of the community, that would be to Adult Protective Services. If the person's in long-term care, that would be to a long-term care ombuds person, the one that's responsible for that facility. So for most of us, it's required if we suspect it. We don't have to have direct evidence, but if we suspect it, we should be reporting. And then driving, this is a really tough one. They linked to the form to report the health condition of dementia. We report to our county health departments and indicate the stage. And then typically the county health department will make a decision and communicate to the DMV in a certain standard way. So there are ways to report, I think, specifically to the DMV in different ways, but it's really our obligation to report to the health department, and then it goes from there. And this has been re-emphasized to me in our own county. So don't forget to report. And then obviously I often disclose to a patient that I'm going to be reporting them, and that they often talk to the DMV, and I'm required to do so. And sometimes it can really help actually to screen. Sorry, I tried to go back in my slides and not go back. There we go. They often are required. And then I often ask if that's going to be a big problem to help them plan and prepare for losing a license potentially, and let them know that I'll be there to follow up and help them figure out how to get services to help them with transportation if that's what's needed. Again, I know this is a very tough issue for many, many people, particularly in areas where there isn't a lot of transportation. And finally, and we're almost done, just to point out that people are eligible for benefits with this diagnosis in the context of the early onset folks for the Social Security Compassion Allowance, and then our Veterans Affairs Californians and other those who may want to pursue long-term care insurance. They may or have benefits already. They may be able to activate those benefits. So I talked a lot. I just want to thank you for your attention. I hope it was helpful to just go through this guideline and that I made things clearer and not more obfuscated. But I do see some questions, and I'm just going to let Pauline tell me how we should be taking the questions.
Thank you so much, Dr.
Sure.
So helpful to have you walk through all that, and there was so much information. We did get about 4 or 5 questions through the chat, and for those who haven't had a chance yet to ask your question, that might be a nice way for us to facilitate that. So on the bottom left corner of your screen, you should see a chat box there, so you can just click on that and then type in your question. So I say we just start from the first question that came in. What do you think, Dr. Chodos?
That sounds great. Happy to.
Good.
So in terms of if someone already lacks capacity and they cannot make decisions, they probably should not fill out a POLST themselves. If they have a surrogate, that person can fill out the POLST. So that would be my answer there. You have the surrogate decision maker fill out the POLST. It's as important if that's the decision that a POLST is appropriate and would be helpful. Again, I tend to use this in people who have a clear desire to, do not resuscitate and have, interest in either limiting hospitalizations or preventing them altogether and don't want tube feeds. So those are the things that are on the POLST. And I fill it out and I record it in our chart and I have them take the original form home and put it on their fridge. Again, if they want, quote unquote, everything, if they want to be full codes at that time and would want resuscitation and would want all interventions, it may not be that, just on a practical level, may not be that useful because that would be the default anyway. So just, I hope that helps clarify that. How do the people,
I don't want to interrupt you. I was thinking maybe I'll read the question out loud for people, and then you can give the response.
Yeah, I just realized that I was going to read the next one. I can do that. So the first question was, if a person lacks capacity, can they sign a Pulse? And then the next question is, how do PCPs work with adult day programs? Do they know the services that are provided there and the benefits of the program? I'm sure it depends on your situation. I think probably many primary care providers don't know enough about adult day health programs, which are typically they're adult day health programs, which are essentially Medi-Cal benefit for people who have functional impairment and would benefit from a day program to remain independent in the community. And those tend to include some transportation and meals, and it's a structured program during the day, often with physical therapy, occupational therapy, and often a nurse on site. So those are amazing programs, and absolutely agree that they're really valuable for people with dementia and who by definition usually have some functional impairment. And in terms of how to get more providers to know about it, I'm not sure, but hopefully this guideline will help a little bit. The next question was, when you say that the older person is living alone and getting dementia, is it because living alone adds to the risk? A really great question. I have that feeling like I know the answer, but I'm not sure, so I'm not going to put my money down that living alone actually increases the risk. I would say living alone makes that person, in my mind, kind of a more vulnerable person. Dementia already makes people very vulnerable, but when they live alone and have dementia, they're hyper vulnerable because often, safety risks and signs of decline aren't caught early enough. So I'm not sure it actually increases the risk. Certainly depression does increase the risk of dementia later on, and things like loneliness can have a big impact on cognition, but I'm not sure about living alone specifically. So sorry that I don't have the exact answer. The next question was, do you recommend any depression assessment tool other than the GDS, which we find hard on patients and not accurate, especially non-white? What a great question. I think I agree. The GDS can be kind of hard on patients. And that is the one that's validated. PQH9 is actually validated in older people too, so you could stick with that one. I know I find that one challenging sometimes with my patients who have limited literacy because it has a lot of choices, like, a scale of a little bit, not a couple days a week, not every day of the week. So it just has that additional difficulty in the assessment. So the GDS is nice because it's yes, no, yes, no. But I agree, some of the questions are tough. You could try the GDS-5, which is just not as long and doesn't quite have as many, quite frankly, depressing questions. I guess that would be my other recommendation, is possibly a PHQ-9 if you're not already using it, and if you feel like your patients could get through it. Next question is, if there are any studies that are in connection with HIV, I'm the founder of the HIV Long-Term Survivors Group. Hello. And I'll say your name because what an incredible thing to found that group, Jesus Guillen. And I'm afraid how Alzheimer's may affect my community. So absolutely so important. There's a really important body of work in cognitive problems in HIV adults, and particularly older adults specifically. It is far more prevalent for people with HIV who have had it for a long time to have cognitive impairment. It's not necessarily Alzheimer's, and frankly, I couldn't tell you what the relative proportion of those with cognitive impairment and HIV, like how much of it is related to Alzheimer's versus HIV-related cognitive disorders. There's a whole spectrum of them. Often it's related to how long someone has had HIV with a high viral load, because we know HIV gets into the brain. And it's actually usually a different picture of symptoms and findings. So it's usually a different profile. So I think probably what's happening is there's the burden of Alzheimer's on top of the burden of HIV-related cognitive problems. So there's a program at UCSF the Memory and Aging Center, and there's a program at San Francisco General at the HIV clinic there, Ward 86. They have a focus on older adults only clinic called the Golden Compass. So you may want to look into those resources to see what information they have. But it is a very important issue in this community, and I would agree. A lot of the care planning principles are the same, as well as in that scenario, specifically controlling the HIV and being careful about the many medications that people have to take. Thank you for that wonderful question. Another wonderful question, providers may also bill Medicare for, there's a comment to make sure we all know, for advanced care planning visits, including post, end of life, and advanced healthcare directives. Thank you so much for that. That is true as well. So there is, if you're able to do it and it makes sense, and your clinic is looking at ways to improve reimbursement in these areas, to also look at some of the advanced care planning billing codes. Thank you. And then the other is to point out that the pulse is great for EMS to show that even if there is full treatment, it may show who the caregiver is. So that's a really good point, that it may just actually be the best way to document the person's surrogate decision maker, and make sure that person is included in the emergency plan. So I guess for some of your patients, if you're thinking about using the pulse for that reason, that may be the best, or the most appropriate reason in that particular patient. The other comment was, my community has many mental health issues. This is also about the HIV positive survivors. Many still not explored, and lots of isolation and loneliness. Couldn't agree more. There's a tremendous amount of loneliness and isolation in older adults in general as well, who obviously have a higher prevalence of and burden of dementia. So there are some, I know the Alzheimer's Association is developing a program in San Francisco area to work with older adults who live alone. We have several community-based groups that work to decrease isolation among older adults. So I often say, like, healthy brain activity is the physical activity, but it's also the social activity. So I just at least try to make my patients aware that that's part of what I consider part of the care plan, is being active and being social. That's sort of what I mean by being active, is physically active and socially active. So these are really important issues. I hope I can get through these. The other question is regarding driving. A resource can be found via the VITAL group, VITAL, which is a 9 Bay Area County consortium of volunteer driver programs. Some are connected via County Area Agency on Aging, MCC, or Caltrans funding for serving non-driving seniors. The coordinator is Mobility Matters in Lafayette, California. So they have a Mobility Matters page at Facebook. And so if people are looking at the chat section, I don't know if they can see me scrolling through, that group is available. So that is really, really key, because I think that it hasn't been an issue for me recently, because many of my folks do take public transportation. But I think for those with in areas where that's not as feasible, it's really important to help people find ways to continue to be mobile and involved in their community if they can't drive. And I'm sorry, I think I skipped a question that was shorter. I would love to know your thoughts on New Dexta. So New Dexta is this medication, which is basically, it's like dextromethorphan and quinidine combination. And I think it's meant for behaviors, if I'm not mistaken. I also think the trials, if I remember correctly, or some of the studies that came out, that also increased falls, and it sort of didn't touch behaviors that much, but did increase falls, or sort of mostly at the same amount. So it's sort of like, I think that's something we're really trying to prevent in older people. I, again, come from a geriatrics viewpoint, where harm reduction is really, really key, especially in these vulnerable folks with dementia. So falls is something I never like to see in the behavior issues I really apologize. I can't recall exactly how successful it was and for what behaviors. I will say that behavior management is something that I'm sure we all we know how difficult this is for patients and caregivers. We wish there was certainly an easy way to manage it. It's just not an easy problem, and medications thus far have not been the solution without also causing harm. So I will forgive me for not having a really firm answer to that thoughtful question, but I think I will just leave it there to see if anybody else has a question who is just on the phone, or if Pauline had anything she needed to get out.
Yeah, I could try unmuting everyone just to see. We have 2 more minutes.
The conference has been unmuted.
Really loud.
The conference has been muted.
That didn't sound good. So I think the chat box was the way to go. So if you have any other comments or questions, please click on the bottom left of your screen. Otherwise, Dr. Chodos, that was really, really helpful, and also appreciated you taking all of these questions. I can't believe we finished in an hour. Really impressed. All right. So just a few more questions are coming in asking about Dr. Chodos's contact information. So we can send that to you specifically. And another question here about how can we engage primary care physicians to assess more frequently? Just realized I muted.
Oh.
Oh, there you go. Sorry, I had you muted.
Oh, that's okay. Yeah, I think I was talking to myself. That's fine. I do that all the time anyway. But yeah, I think that is a wonderful point, and that was really our hope with the guideline, is that by promoting it, people will look at it and use it. And one of the key recommendations is to monitor regularly. So I would promote the guideline if you feel like that's something your health system and PCPs would respond to. And certainly the DPH will do its efforts on that, and Alzheimer's Association is doing its efforts. I'm doing similar efforts in our health system. So it's the best we can hope for. We just all know that this is a time-consuming thing, and PCPs often, even myself, feel uncomfortable with it in a general setting. It can be really hard. So the more we can educate and promote guidelines like this, I think that's right now at least something we can do. And I'm happy to share my contact information. Pauline, if you can send that out in the follow-up, feel free to contact me at any time. Mm-hmm.
Great. And we did record the webinar today, so I think that's another great way to engage primary care providers or other professionals, care managers, et cetera, with this information along with the guidelines themselves, plus also public policy and advocacy efforts, I think, are critical for reaching more PCPs. So with that, it's exactly 1 o'clock. So what we'll do is we recorded the webinar today, so I will send a follow-up email to everyone with the link to that, as well as several people have asked for a copy of the PowerPoint, as well as contact information. So we will follow up with that information, and if there's any questions that didn't get answered, feel free to reach out to the Alzheimer's Association, and Dr. Chodos has offered to help as well. So we are so glad that you joined us today. So thank you so much all again, and have a good afternoon.
Thanks, everyone. Bye.